Nerve supply of ear. First we have nerve supply of pinna, greaterly supplied by greater auricular nerve C2, C3, cervical plexus. Then we have lesser occipital nerve, auriculotemporal nerve, Arnold nerve with facial nerve. That is mnemonic will be GOAA. Greater auricular nerve supplying the medial surface and even majority of the lateral surface of pinna. Lesser occipital nerve supplying the superior portion of the medial surface of pinna. Auriculotemporal nerve, which is a branch of mandibular branch of trigeminal nerve, supplying tragus, crus of helix and adjacent helix. Or Arnold nerve, branch of vagus nerve with facial nerve, will supply concha and antihelix. These two nerves will continue to supply external auditory canal. We have anterior wall and roof. Anterior wall and roof supplied by auriculotemporal nerve of mandibular branch of trigeminal nerve. And then we have floor and posterior wall supplied by another A, that is Arnold nerve. Arnold nerve, branch from vagus nerve with facial nerve. These two nerves will continue to supply the lateral portion of tympanic membrane, whereas medial surface of tympanic membrane will be supplied from nerve supplying the middle ear. Middle ear sensory supply is from glossopharyngeal nerve, that is 9th cranial nerve, Jacobson plexus around the tympanum. Sensory supply was from glossopharyngeal nerve, whereas motor we have two muscles, tensor tympani and stapedius. Tensor tympani is they have origin from first arch. First arch nerve is 5th cranial nerve, that is trigeminal nerve. Stapedius is a second arch muscle, therefore nerve supplies 7th cranial nerve, facial nerve. Now we have referred otalgia. When this we know the external air is totally supplied by 5th cranial nerve, 7th cranial nerve, 9th cranial nerve and C2, C3 cervical plexus. Any pain, these structure also supply some other these now also supply some other structure in the head and neck. So referred pain, if it is in related to dental, anterior oral cavity, TMJ joint, temporomandibular joint and parotid, the pain will be referred via 5th cranial nerve. Whereas any inflammation or infection in tonsils, posterior 1/3 of tongue, even posterior pharyngeal wall will be supplied by glossopharyngeal nerve, which will refer the pain to external ear. And C2, C3 we have spondylitis, which is referred to ear via greater auricular and lesser occipital nerve. And middle ear is also supplied by 10th cranial nerve, which Arnold nerve. Now that referred pain will be originating from larynx, hypopharynx and even cervical plexus, cervical esophagus. Then we have inner ear. Inner ear as bony labyrinth and membranous labyrinth. The limb inside the bony labyrinth we have perilimb. Inside the membranous labyrinth we have endolimb. Bony labyrinth is the outside, which is made up of cochlea, vestibule and semicircular canals. Inside cochlea we have cochlear duct. Vestibule will have utricle and saccule. Inside the semicircular canals we will have semicircular canals respectively, posterior, lateral and superior semicircular canals. Sensory structures inside this will be, for hearing we have cochlea, which has organ of Corti. Cochlea has totally 2 3/4 turns. Apical, we have apical and basal turns. Apical has less space, Remember, it will be low frequency sounds will be picked up here. Basal will be high frequency sounds will be picked up here. For utricle and saccule is for balance. We have utricle saccule is for linear acceleration, whereas semicircular canals is for rotational acceleration or angular decelerations. Structures present in utricle and saccule for these sensations is called macula. In semicircular canals we have cristae. Now nerve supply of this, we have a 8th cranial nerve, which is vestibulo and cochlear nerve. Where cochlear branch will supply cochlea. Vestibular branch is divided into superior and inferior divisions. Superior division will supply upper parts, that is utricle, superior semicircular canal and lateral semicircular canal, whereas inferior division will supply saccule and posterior semicircular canals. Okay. Again same, we have arterial supply of inner ear. We have labyrinthine artery, which is a branch of ICA, that is anterior-inferior cerebellar artery, or it may have a direct branch from basilar artery also. It will have two branches, common cochlear branch or artery, and then we have anterior vestibular artery. Anterior vestibular artery will supply utricle, superior semicircular canals and lateral semicircular canal, that is anterior vestibular artery. And then we have common cochlear artery dividing into again two branches, cochlear branch and vestibular branch. Cochlear branch supplying the cochlea, whereas vestibular branch will supply saccule and posterior semicircular canals. Vestibular branch of common cochlear artery. Now we have malformations to be learned. We have malformations in external ear and inner ear. External ear, there can be microtia or it can be total absence, anotia. In this, there is, for using earring implants, Baha can be used, bone anchored earring gates can be used. In inner ear deformity, we know bony labyrinth and membranous labyrinth. Bony labyrinth has cochlea, vestibule and superior semicircular canals, and membranous labyrinth include cochlear duct, endolymphatic duct, utricle and saccule. Defects of cochlea can be either to MA, that is Mondini dysplasia or Alexander dysplasia. Mondini dysplasia is when the turn of cochlea is normally 2 1/4 to 3/4 ton. Here it will be just 1.5 tons of cochlea, whereas Alexander dysplasia is basal turn of cochlea is defective, that is high frequency will be affected. In both the cases, there is use of cochlear implants can be done. Cochlear implants can be used. Then we have defects in both the bony labyrinth and membranous labyrinth. It will be M and S, that is Michael aplasia, and then we have Schibbe dysplasia. Aplasia is total absent of bony labyrinth and membranous labyrinth. Absent. There is no use of then contraindication to cochlear implant itself. Whereas Schebe dysplasia is a most common type of malformation seen where it is autosomal recessively inherited disease. There is cochleo and sacule dysplasia, C plus S. And then we have defects of cochlear alone. We have defects of membranous labyrinth alone, which will be called membranous labyrinth alone, where there is absence of membranous labyrinth called Binge-Schieberman dysplasia. Binge-Schieberman dysplasia. Schieberman dysplasia. Here also there is use of cochlear implants can be done. Okay, we have cochlear alone, MA, that is Mondini and Alexander, both the bony labyrinth and membranous labyrinth. If it is absent, it is called microplasia. If it is dysplasia, then it is Schebe dysplasia. Cochleoscapular dysplasia, which is most common type of malformation seen. And we have total absence of membranous labyrinth called Binge-Schieberman dysplasia.